Thank you for joining us today for today's webinar on preparing general practitioners for the Support at Home program. My name is Jason Phillips and I'm the Aged Care Manager here with Central Eastern Sydney Primary Health Network. Before we begin, I'd like to start by acknowledging the traditional custodians and sovereign people of the land across which we work. I recognise their continuing connection to land, water and community and pay respect to elders past, present and emerging. I also extend that respect to Aboriginal and Torres Strait Islander peoples joining us today. Just a bit of housekeeping before you post any questions in the Q&A function. Please post your questions in the Q&A function and note that the chat function is disabled. As you would have heard, the meeting is being recorded. At the end of the webinar, an evaluation survey will pop up on your screens. We'd appreciate your feedback, so please complete this and allow us to issue your certificates of attendance. I'd like to now introduce today's speaker or presenter, which is Wendy O'Meara. Wendy has a long history in general practice spanning 27 years. She currently works as a practice manager in a large 24 GP practice in Gisborne, Victoria. She's passionate about general practice and has a thorough understanding of all facets, with a special interest in the MBS and chronic disease management. While working full-time, she still takes time and opportunities to meet with and work with new practice managers, guiding them through the complexities of general practice. She's been working as an educator consultant since 2017, and she's very well placed for today's presentation. So over to you, Wendy.
Thank you so much, Jason, and welcome everyone. Thank you for taking the time out of your busy day to spend with us. I hope I'll make it worth your while. So before I begin, I would also like to acknowledge the traditional custodians of the lands on which we are virtually meeting today and pay my respects to elders both past and present. And I would like to also extend that respect to any First Nations peoples here with us today. So today's topic has been a little bit overshadowed. Introduced on the 1st of November, along with the BBPIP and everything else. So this has got a little bit lost in the transition. So I think it's timely that we are aware of this program if you're not already. And today I'm going to step you through what it is and how GPs particularly play such a vital role in this program. So today, at the end of today's session, we're going to cover what training is available, along with what the Support at Home program is, the classification levels, along with the structure and what it looks like compared to our previous home care package system. We'll also look at the important role GPs will play, particularly around the referral process and the benefits of engaging a multidisciplinary team. And we will also cover off on the 3 new short-term supports, including end-of-life, restorative care and assistive technology in home applications. So it sounds like a lot, but trust me, it's quite simple. So it will be a very general overview today, just to get you aware of what's happened and what we can do as in general practice to support our patients. So the Support at Home program is a new aged care model introduced on November 1, 2025. It was introduced as part of the Royal Commission into Aged Care Quality and Safety, and one of their recommendations was to better support for the elderly living in the community to prevent them having to transition to aged care. The package replaces the current home care package and the short-term restorative care program that we have, and the remaining Commonwealth Home Care Support Program will transition in or around July 2027. The aim of the program is to make care easier to navigate for GPs and to improve coordination, strengthening clinical insight. But I think the main purpose is to ensure our elderly population who are living at home receive the right level of support at the right time. I think that's probably the key takeaway. What does it mean to you as a GP? The new package means GPs will be able to refer their patients to a wider range of support services. And when we combine this with the changes or the introduction of the 3 new classifications, the aim will be to assist our elderly patients to remain in their homes for as long as possible. Asset testing will remain, and the amount of funding approved will depend on this. Patients may be expected to make contributions to their care, and I will talk a little bit more about that later. So what is the supported home program? What does it mean to us? It's basically a uniformed model which is going to make it easier for us in general practice to understand what services our patients can receive at home. So we'll need to ensure the referrals are comprehensive and all medical needs are documented, as this will directly influence the assessment outcomes and the level of access the patients are allocated to. Having a thorough understanding of the new program will help you to assist your patients in navigating the new system. So there may be many patients who are already on the previous home care package. They will be transitioned to this new supported home program and have probably already been done so, but anyone newly registered will be registered to the supported home program. So the key changes are obviously the added level of flexibility about the program, what the GPs are now able to refer for. It allows us to implement allied health intervention, falls prevention supports, medication management, which is a big risk for our elderly patients, particularly around medication misadventure. And as we know, many of our unplanned hospital admissions for people over 80 are due to medication errors. And of course, the short-term re-enablement. So following an illness or injury, patients will be able to be referred to a short-term course, or short-term program that will get them back on their feet much quicker. The outcome of an assessment will provide a much more tailored plan that supports both functional impairment, reduces the risk to the patients, and takes into account the individual's complexities. By providing all diagnosis and complexities and the impact these are having on the patient, it will allow the assessor who is performing the assessment to get the better picture. So the more information we provide to the supported home program through our referral, the better the outcomes are going to be for our patient. The GP will need to assess all the risks associated with the patient being at home and identify services that will best support the patient to remain independent. When the aged care assessment is conducted, the assessors will request or may request, I should say may, shouldn't say will, may request further information use for such things as health summaries, medication lists, and any particular information which you think will guide the decision making for them. We also need to review their care and refer for additional services should their needs change significantly. So it's not just about that initial referral, it's about that regular review if a patient has a dramatic change in their situation or their circumstances. Let's look at what the differences are between the old home care packages and the new supported home model. So obviously, previously, patients were assessed and assigned a package level depending on their needs, based from level 1 to having low needs to level 4 having more complex needs. With the new system, there is no actual level, and the support that is provided will match the assessed needs directly. Previously, with the home care package model, funds were held and controlled by the provider, whereas in the new support system, funds will be allocated to the person and the provider will deliver the plan. Whereas previously, reassessments were very slow, and I can talk from personal experience. Both my parents were assessed and unfortunately passed away before any care was implemented. So reassessments when there's a change of condition was traditionally very slow. However, now there is a much more streamlined process for us to be able to update things quickly. Care planning plays a big role in any referrals, and we're going to look a little bit more about how your care planning can enhance the services and support levels our patients can access. And often patients would care with the old package, care would drift between different providers, whereas with the support package, it aligns to clinical priorities and goals and not so much the provider. So that is a basic difference. With responsibilities for the GPs, as you know, we are usually the first point of call where a decline is noticed. We see patients whose gait may have changed, or they're not able to walk as independently or as confidently as they used to. Cognitive changes, functional decline, they become more frail, or they're not eating properly. Stresses from the carers, or the carer is stressed, and of course we would then initiate appropriate referrals. So by looking for these things within our patient cohort, we are able to now implement services much sooner with the goal of keeping our patients at home. And that is the underlying theme for this whole program, is to implement services for our patients to prevent them being hospitalized, having falls, or having to transition to aged care. Under the new model, medication safety is a priority, and GP's responsibilities may include such things as reviewing the medication complexities. So looking at what your patients are taking, ensuring suitability for home-based medication administration, whether it be that they have a Webster pack or a dosette box, communicating changes with home support providers, so any changes to your patients. And the big key, I think, in this slide is supporting pharmacist-led reviews. So implementing those home medication reviews that we have available to us to ensure that our patients' medication management is appropriate and that they are well aware of what they take, when they take it, and what it's for. So what does Support at Home provide? Basically a whole range of services, help with showering and dressing, so the old, personal care, meal support and nutrition, so dietitian advice, cleaning, laundry and home maintenance, transport for appointments, which has been a big gap, in previous services, nursing care and wound care at home, physio, OT, podiatry, and other allied health services, and then the home modifications such as rails, ramps, any kind of adjustments that are required to ensure our patients are safe in their home. Of course, it's also the ability to have a referral to a falls prevention and mobility program. So as you can see, all the services that we are able to now refer to are all very relevant to our elderly population. What is not changing, however, is some of the processes. So previously, we referred patients for aged care assessments under the My Aged Care. That has not changed. We will continue to do that. Making clinical decisions with older people, including the medications and recommending other supports, is still within our scope of practice and should be still completed regularly. Guiding patients through care options and pathways. Our role is to support our patients through that process of engaging services relevant to their needs and supporting access that matches the person's individual needs. So, ensuring that the provision of service that is allocated to them actually does meet their needs. We also need to work with our multidisciplinary team. I'll spit that one out in a minute, to coordinate the support and improve health outcomes. So it's not just about handing our patients over to these other providers and forgetting about them. And a good way of working with our allied health providers is through case conferencing. So it's not used enough in general practice. There is a big opportunity for us to further engage with other providers, particularly the team who are looking after our elderly, to make sure we're all on the same page and we all know what our patients' needs are. So that's a little overview of what the program is. Now let's look at what the eligibility criteria is. So under the new Act, which was the Aged Care Act 2024, the following groups will be eligible for an aged care assessment. So we have our people over 65 years and over, so they can be 65, they have to be 66. Any First Nations people over the age of 50 or older, and any persons over 50 who are homeless or are at risk of homelessness. So if you know any of your patient cohort are in that group, they are certainly a group of patients that we can engage with. Beyond the age criteria, they must also have assessed age-related care needs. What do I mean by that? Obviously, the things we talked about previously, physical function, cognition, social difficulties or difficulties with activities of daily living, and just in general, a poorer quality of life. Or they require assistance through technology, equipment, or support, such as help in the use of equipment or products to stay physically, mentally, or socially able to function independently. So, all of those services and assistive technology that we can implement to keep our patients independent for as long as possible. Let's look at the referral process. So, not much has changed with this. To support the timely and accurate referrals, obviously we would be still lodging our referrals through My Aged Care, and you can do that in multiple ways. So you can do it on the Aged Care website, the My Aged Care website. You can do it directly from your clinical software through HealthLink. The Aged Care referral is available through HealthLink, and I'm sure the PHN can help you with that. Phone referral by calling My Aged Care, which is a very time consuming, and I'm tipping with all this new everything kicking off now, will probably be a long consult. So perhaps the online version is probably better for our time management. And the ability for patients to continue to self-refer has not changed. So patients or carers can absolutely self-refer. However, I will say to this that when we looked back at the criteria and the importance of the GP's contribution to the information that's provided, it would be much better coming from a GP. So we are encouraging our patients to come to us to refer so that we can make sure that the information is comprehensive enough to ensure our patients receive the appropriate care. Assessors will increasingly rely on us in general practice for things like recent medical summaries, any functional decline observations, medication risk factors, of course, the impact of the chronic disease condition they are living with, any changes in cognition, mobility, issues with continence and safety concerns, because this will improve the accuracy of the assessment and ensure the patients are matched to the right level of care. And I'm going to talk a little bit later about the potential MBS item numbers you could use to actually get this information in a more simpler format. As an overview, this is what the referral process is going to look like. So the patient is referred or registers with My Aged Care and is screened. There is a triage process. So once the referrals come in, there is a process of triaging to ensure that our patients who need urgent care are triaged above those who need low-risk care. The patient is triaged and the aged care assessment is organised and completed, with a support plan being a result of that. So the interview is held, and a report is submitted. The provider will accept the My Aged Care referral. So I'll beg your pardon, I'm skipping. Participants will receive a notice of decision based on what level or what classification of care. We're going to talk about the new classification shortly, but what classification of care they have been allocated and what type of funding they're going to be receiving as a result of that classification. Then there will be an acceptance of referrals from the providers that have been nominated to provide the care. The participant will complete an income and assessment at this point to determine whether there is going to be any co-payments, with the provider and participant entering a service agreement and developing a care plan. So that's a key point. There will be a care plan developed from each provider to show what the outcomes of the service provision are going to be. So it's something that's measurable, which I think is really good. Then provider notifies the Service Australia that the participant has started the care. So that's probably a bit of a, short version, but a really good one-page document to have beside you if you want to explain the process to your patients. So let's now look at how the classifications have gone from a package level 1 to 4 to a set of new classifications. Understanding how services are structured does allow you to provide those appropriate care plans. So I've spoken before about the need for us to provide as much information as we can. And once you see the level of funding and how it's actually made up, it's going to make that clearer for you. The Support at Home package has 8 ongoing classifications linked to different levels of care. So not 4, we now have 8. The classifications are based on the level of care required. The higher the level of required care, the higher your patient is going to be classified into. These are the 8 classifications. Apologies, it's not quite as big as I would have liked, but I did want to, and I'm not going to read this word for word, but basically you can see that level or classification 1 is basic support, where the patient might need a bit of home help for cleaning, and perhaps some minor equipment like a walking stick, and they may also require occasional transport. Right through to level 7, which is that intensive clinical support, where they're going to require high frequency things like nursing, advanced wound care, and other types of monitoring. So it's a very good overview of where where the classifications fall. So as you can see, the more information we provide will allow the patients to be classified in a level more suitable to them. These are the funding amounts. Remember, as we talked before, the funding goes to the patient, not the provider. So if a patient receives a classification of level 1, they will get a quarterly budget of a bit over $2,500 with an annual amount of $10,700, right down to level 8, which is around $78,000 a year. So they are quarterly budgets and they are indexed annually from the 1st of November. So July, I think they're indexed twice actually, but the next change will be July next year. So that's what we're looking at. So our patients have quite considerable access to funding, depending on their classification level. Alongside the 8 classification levels, there are also 3 short-term classifications, and these are available on top of the funding that they've been approved. So their funding will come from the classification level they are determined to be most fitting for them. And then there are opportunities to access further pools of funding for the 3 new programs. So the restorative care pathway we already had previously, and we did have a less trying to think of the word, the previous at-home modifications we had was not quite as comprehensive as the new one. And the new thing, which I think is just fantastic, I'm so happy about it, is the end-of-life pathway. So these are the 3 additional short-term classifications that can be approved for funding on top of the original funding. I talked before about patient contributions, and I just want to basically cover off on that a little bit. As I said, they are income and asset tested to determine if patients are required to make a contribution to services, and the contribution rate will be set as a percentage of the service. So if a patient doesn't need to make any contributions because their assets and income does not meet the minimum, they will make no contributions for clinical support services, nursing, or physio. So if they are the only services they need, there is no contribution required. If they require things like independent services like personal care or assistive technology, there may be a moderate contribution up to the highest contribution where there is requirement for domestic assistance and gardening. So things that require further intervention. So with a lifetime cap of 135,000, which is what is the most the patient will pay in their lifetime for a co-contribution or for a contribution to their care, which sounds like a lot of money, doesn't it? But if this is over a 10-year period, it's only $13,000 a year. So once the patients meet the cap, they will no longer be required to make a contribution. And please remember, this is income and asset test. If they are not meeting the threshold, they should not be required to have any contributions. Now, I'm going to cover off on the 3 pathways, which are probably the most relevant to us today. The purpose of the end of life pathway is basically designed to ensure we can keep our patients at home if they choose to stay at home to die. So the package will allow us to organise comfort-focused care with symptom management as a priority. It will reduce avoidable hospital presentations. A patient won't have to go to hospital because we will have the services in place to manage them at home. They'll have access to nursing, personal care, and respite services for the family if they need them. Support for carers during the final weeks to months of life. And as I said before, very personal for me. I cared for both my parents before they died, and it was really, really hard. So I think this had been around then would have been a great help. There'll be that coordination between the clinical and non-clinical services. And of course, for GPs, it creates a clearer, better supported picture for how you're going to manage your patients' palliative care at home. Who's eligible? The patient may enter the end of life stream when they have one of the following: a life-limiting illness, so they say less than 3 months, a progressive functional decline, a prognosis where the goals of care shift to comfort, so where a patient has been marked, deemed as palliative, and all we're going to do is try and keep them comfortable. And they'll also have increased need for personal care, nursing, or equipment. So a GP's confirmation is required and a prognosis is required to activate the end of life support. So you as a GP need to make these decisions about where the patient is in any of those above criteria, because you will be the one that's applying for the end of life pathway through a form. What supports are available to our patients? The program provides flexible but rapid response support. So this is one of the programs that will be prioritized. So if your patient is enrolled in this program, the services will be activated quickly. But what can they access? So obviously community palliative nursing, who can manage pain and symptoms, wound care, any terminal phase support. They can anticipate what types of medication are going to be required, and of course the option for overnight or emergency nurses where available. So that's number 1. Personal and home care, so assistance with bathing, toilet, or feeding, any time pressure care, wound care, and positioning, and again, that overnight support. The emotional and carer support. Obviously, we need to look after our carers because losing someone is a very challenging, very distressing time of your life, and to have that support is really important. Equipment and aids, so fast-tracked also hospital beds to keep the patient comfortable, be able to put the rails up or to be able to put the bed up and down. Any kind, pressure mattresses, commodes, any kind of hoist if you need to move your patient, your parent or your family member around, and then mobility and safety equipment, and then coordination with specialist palliative care services. There will be palliative care services engaged to share the care between the GP with any after hours escalation plan. So as you can see, it's a really great pathway, but we are central to this. So the GP is central to setting the goals of care. So as a GP, you will set what goals are required for your patient to manage their care. You'll continue to review changes in the condition, whether it be through home visits or through feedback from other providers. Ensuring the treatment aligns with the patient's wishes. That's a really big, important thing, that if the patient is choosing to die at home and they've got their wishes documented, that allows us to ensure that that's met. We can provide anticipatory medications, things that may be required towards end stage, and this was going to avoid that crisis-driven hospitalization that sometimes impacts on our patients through no fault of their own. With symptom management, you'll support the patients through the things that you already do with your patients who are palliative, pain being probably the most significant thing to manage. if they're breathless, to particular medications for breathlessness, nausea, and secretions, delirium, anxiety. The end of life stream ensures nursing coverage also, so the GP's plan is carried out in real time. So what am I talking about? You could do a palliative care plan, you could do an advanced care directive. So all of these things are important for us if we are accessing the end of life pathway. As I said, advanced care planning is important because you then know what the patient wants. We should be encourage all our patients to complete advanced care directives because it's so important, particularly if the end of life care comes quicker than anticipated. So what the patient values, what their goals are. Do they want to have CPR? Do they want resuscitation, or do they not want to be resuscitated? Where they'd like to be cared for, and things after death. Always important is a substitute decision maker. So whether it be a medical power of attorney or a financial power of attorney, I guess our relevance is around the medical power of attorney. And of course, this program supports all that because, as you know, everything that I've said supports that care and the planning of the GP. We also play a big role in the anticipation of what types of medication our patients may require. So those anticipatory things such as opioids or antiemetics, ensuring we have a just-in-case kit. And as you know, that's basically a pre-packed supply of medication along with necessary equipment such as syringes to help manage those distressing symptoms that usually arise near end of life. And deprescribing, so reducing or ceasing those inappropriate or not essential medications, so blood pressure tablets and cholesterol tablets, all those things are not necessary towards patients' end of life, so we can play a big part in reducing those. Of course, the multidisciplinary team coordination, you are the instigator, so you're the center of this team. So you'll be working alongside palliative care specialists, our community nurses or our palliative care nurses, pharmacists, any type of allied health that may be engaged, and of course the carers and families. So it's a big burden, isn't it? The end-of-life pathway will expect the GP to, in their application, provide updated clinical summaries identifying the patient's condition, clarify goals when symptoms worsen, adjust medications, communicate expected trajectory, that's a difficult word to say, to the care team, because this will prevent the patient being presented or being sent to ED. So important that we communicate clearly what it is that the patient's expecting from us. The end of life stream, integrating it with our workflow. The benefits to us are it's better community support. So by engaging this or instigating the end of life pathway, our patients will be well supported and managed at home. There's better communication, the confidence that the home setting is going to be safe. So the use of the services we mentioned before, hospital bedding and different safety devices is certainly going to make it much more safer for the patient, and along with the improved carer support. So ensuring we have things in place to reduce that fatigue that comes with caring for someone who's palliative. Okay, of note, if a participant still needs services after the 12-week period, so 12 weeks is the set period, however, that doesn't always work out that way. The patient can continue to access the budget up until the 16-week mark if there is still a budget available. So and I'll show you what the budget's going to be in a minute. So if the budget has been eaten up, the patient may be able to access further funds from the unspent home care packaging funding, or they can work with the providers to request a support plan review to provide more funding. So interim funding does not apply to end of life pathway. So there is a process of interim funding. However, it does not apply to this particular pathway. This is the form that GP will need to complete to enroll their patients in the end of life pathway. It's only 2 pages. It's not complex, but I think the relevant documentation we attach to it, like health assessments and care plans, are all going to be much more valuable. So what should you do? First of all, when we're looking at workflow, do you have any patients who are palliative? So identifying these patients early, having the discussion with them about how they would like to, what kind of end of life care they would like to have. Update their advanced care plans in their My Health record, because as you know, you upload the My Advanced Care Directive to the My Health record, but update it in your clinical record so you know what the patient wants. Hold a goals of care discussion with the patient and the family. Communicate prognosis and care intent to the My Aged Care or the assessor. So this is what we want to do. Ensure the medication plan and after hours instructions are clear. So have a well-documented medication sheet or directive along with any after hours. You might say, yes, if there are any issues after hours, I want you to call me, or I want you to call this service. And of course, liaise with community nursing to set monitoring parameters. So we've got lots of work to do, haven't we? There's the end of life pathway funding. So as you can see, $25,000 is provided for a 12-week episode, which may be extended to 16 weeks. So after that time, they either access funding from previous pools or we reapply for some another set of funding. Okay, then we have the assistive technology and home modifications, which you'll see in all documents basically is just references ATHM. We are again, as I said before, the first point of call to notice those declines, so that mobility limitation, difficulties with daily living. So this is often identified at a health assessment. So this is where a health assessment would be really valuable for you to conduct on all your patients who are 75 and over, because all of the criteria that we have listed here is a component of your health assessment questionnaire. So it will allow you to, so the next time you're reviewing your health assessments that may have been done for you by the nurse, remember that these components are important in the application of funding. You will provide things again for the assessment, past relevant history, so could have had a stroke or they may be suffering from dementia. Medication reviews, so it would be great to have a recent medication review and any effects that some of those medications have on the mobility of the patient. Sensory impairments, so whether they've got vision or hearing impairments, and of course whether they have any cognitive declines, which you would do as part of your K10 or not K10, your MMSE, your mini mental, or another whatever program, whatever questionnaire you use. Older people will be assessed for the ATHM scheme as part of their aged care assessment, and if needed, approved for suitable funding tiers. There are two tiers. There's the assistive technology funding tier and the home modification funding tier, or both. So a patient can have access to one or the other or both, depending on their needs. And the ATHM funding will be available immediately for the restorative care and end-of-life pathway. So that's something to know as well. It will be fast-tracked if those patients are on those other programs. What kind of supports are available? Mobility aids, shower chairs and toilets, bed rails, hoist ramps, door widening, which is, I could have used that when I was trying to get the fridge out of my kitchen, fall sensors, smart monitoring, and of course, pressure care equipment. The role of the GP obviously is to recommend the types of equipment that you believe would be beneficial, that will support the OT, by providing clinical information to justify the modification. So documenting and acknowledging why you think the patient would benefit from these additional services, making sure the equipment aligns with the diagnosis and the functional limitations. So making sure that the patients aren't receiving something that they can't use. With the aim, of course, of reducing falls, pressure injuries, and avoidable hospitalizations. So I talked before briefly about the GPCCMP, and this is the most important time. So we often forget about palliative care, particularly with the GPCCMP, but this is where the care structure is needed the most. So if you are a GP who doesn't regularly do care planning, and you have patients who require aged care assessments, this is where you should start. And this here is basically an overview of what we collect anyway, but as you can see, it provides it's good provision of information to facilitate the referral and give as much information as needed. That is the funding. So if the patients are classified as needing low level of assistance, they get a $500 cap over 500, and it goes up to $15,000 over 12 months if they have high needs. And patient participants who have the ATA assistive technology costs above 15,000 can access additional funding with evidence. So if you require further services, as long as the GP can provide evidence that yes, it's warranted, then further assistance can be attracted. And the final pathway, the restorative care pathway, which we did have in the home care package in a more simplified version, I guess. But again, this short-term goal, again, it's a short-term program, is designed to help our older patients maintain independence. So it aims to reverse slow functional decline, improve mobility, strength, and confidence, particularly after long stays in hospital or post-fall, and restores independence in daily activities. With the bottom one, I think is the most probably telltale, is the reduction of falls, hospitalization, and having to go to an aged care facility. Under the supported home, the restorative care pathway becomes more integrated. So your GP involvement includes recognizing patients, so having those conversations or determining eligibility, confirming the clinical stability to participate. So ensuring the patient is able to participate with the program. So physio may need a patient to be at a certain level and they may deteriorate. Communicating goals, and of course, reviewing progress and adjusting any medication as the patient's conditions improve. The restorative care pathway has 4 main components, so it's time limited. It's usually up to 16 weeks with an intensive support early and tapered follow-up. The person sets functional goals, so the person is involved in the goal setting. I just want to walk to the letterbox. I want to be able to shower on my own. I want to cook meals again. The multidisciplinary team is engaged and designed with the aim of preventing further decline, and most of these services, all these services are actually home based. So as you can see, receiving care at home to keep them home and assist them with goals that they have. There's a restorative care pathway, $6,000 or up to $12,000, because if you get to the 16 weeks and the patient has still not fully recovered, the GP can apply for a second round of funding. So we can get up to $12,000 per year for our patients. So what should we be doing, GPs? We should be reviewing our older patients for early functional change. We need to strengthen our relationships with our multidisciplinary team, so our nurses, our community nurses, our physios, OTs, or any social workers. Use the existing MBS items you have to support that comprehensive care. And as I've already mentioned, conduct your GP-CCMPs, do your medication reviews, and conduct your health assessments, because that's going to inform good decision making. Familiarize yourself with the supported home referral process and encourage your patients to plan early. So encourage your patients to start looking at, as they age, what are they going to need? What can your team do? So obviously we have a huge team besides you, the GP. So identifying risks, your receptionists are really good at noticing changes in patterns of our elderly. Practice nurse can do those care planning and functional screenings for you. Your nurse or practice manager can follow up patients after hospital admissions to check, has there been any risk to them after discharge? And the ensuring recalls for reviews are put in place, and that they're actually happening. And your reception team can also do that for you. So there is an online training module available to help the GP better understand the program. While the focus of the module is more for the providers, so it's more about the service providers, it certainly does give you many resources and guidelines to help you understand this program better. I have put the link here, but I've also put the link in the last page where all the resources are kept. So to sum it all up, the supported home package is a single streamlined program replacing community home services, home care packages, and short-term restorative care. It's a needs-based assessment that will match appropriate care to our older patients depending on their functionality. There are service provision for maintaining independence at home, covering personal care and domestic assistance through either the ATHM modifications or the restorative care, and the stronger focus on early intervention and re-enablement, ensuring our older people receive short-term goal-focused care to prevent decline and stay independent for as long as possible. So there's a list of resources. You will get a copy of this PDF, so you'll be able to access that at any time. I'm now going to stop sharing so I can see whether there are any questions.
Hi, Wendy. There were a couple of questions there. I'll pop some answers into the chat. Do you want to have a quick look at them? The first first question was what forms need to be completed, and are they online, and are they integrated with general practice software? So
yes, so
yes,
the aged care assessment is definitely integrated with most clinical softwares through HealthLink. So if you haven't used it before, jump onto HealthLink because the aged care referral is there.
And then there's just a couple of other questions there around finding the HealthLink icon in general practice software.
Yeah, did we answer that? Yep.
Yeah, I've answered it. I think
Thank you.
it's pretty well done.
Yep, thank you. And what is the name of the tab used for health and referral? Well, yeah, so best practice, they have got it's a HL, just has a H and a L. So you can access it quickly. But yeah, it is great. It's so much quicker than having to go onto onto an online form, and it's much quicker because it's an immediate submission. So, well, thank you for answering those questions for me, Jason.
That's all right, Wendy. So I'd just like to conclude by thanking Wendy for a great presentation. I want to thank everybody for attending. Please complete the evaluation survey. We appreciate your feedback and ongoing support, and we look forward to seeing you all in 2026. Thanks, everybody.
Thank you.